thinning of the hair, and also menstrual changes, which is decreased or irregular menstruation, or sorry, heavier than normal, but also irregular. So, how can we diagnose? Are we going to diagnose hypo or hyperthyroidism in the ER? Mostly not, because these patients are usually following up in clinics where they are diagnosed there or as inpatient patients, and they come to us in the ER already established hypo or hyperthyroidism. But to make this simple, we are going to focus on the lab tests that are done to diagnose these conditions. So this is a common question in the emergency board where they ask you which is the most important test to do for endocrine emergencies or endocrine diseases. So TSH is the most important lab test that you should do, but you should also have a free T4 and T3 level, which will help you diagnose this whichever condition this patient is having. So in primary hypothyroidism, the TSH is elevated, where the free T3 and T4 are low. In subclinical or secondary hyperthyroidism, the TSH does not have to be as elevated as in primary hypothyroidism, um, but the T4 level would be normal in subclinical hypothyroidism, and it will be low in secondary hypothyroidism, such as primary. What lab tests would we do in the emergency department? We are going to assess this patient as any other patients. We're going to do a CBC, urine electrolytes, random blood glucose, ECGs, chest X-rays, to see what could have caused this patient to come with new symptoms that were not there before. So, simple hypothyroidism, usually we do not see them in the, as I said, as a new case diagnosis in the ER. But that could happen if you have a very wide differential and you start ruling them out and you cannot find what caused this condition. So before we talk about management, let's talk about the causes. Hypothyroidism or primary hypothyroidism, the most common cause is Hashimoto's thyroiditis. What happens is it's an inflammation of the gland. So a fun fact about the thyroid, it is one or the only gland in the body that stores its hormones for a very long period of time. So it can supply up to 100 days after the injury or the insult occurs. So initially, in Hashimoto's thyroiditis, this patient would have elevated serums of T4 and T3 and low TSH, which means he or she will be in hyperthyroidism initially because of the inflammation. This means we have release of the thyroid glands, thyroid hormones from the gland, and then this patient will go into hypothyroidism. Secondary hypothyroidism, as we said, it is caused by extraglandular issues. So these patients need to have other kinds of workup, including CT brain, to see which insult occurred exactly. So management-wise, in simple hypothyroidism, we're just going to do supportive management, which means we're just going to take care of the airway, breathing and circulation, make sure the patient's getting enough fluids. We will correct any electrolyte disturbances. But in the condition, if we diagnose a new case of hypothyroidism in the ER, we can start levothyroxine with consultation of an endocrinologist on board. Okay, in healthy young adults, the dosage should be 50 micrograms per day, and older than 50 patients or in cardiac disease patients, we should have a lower dose. So we would start at 12.5 to 25 micrograms per day, and we should discharge these patients to follow up with the endocrinologist to adjust the dose as the disease progresses with time. So what is the most dangerous form of hypothyroidism? It would be myxedema crisis. It is a state of metabolic and multi-organ decompensation, which is characterized by hypothyroidism. It is a very serious condition. You should be very vigilant in the ER in diagnosing myxedema coma or myxedema crisis, sorry, because its mortality rate is between 30 and 60%, and that is pretty high. So what are these signs and symptoms that we could see? Of course, the patient would have the same symptoms of hypothyroidism, but they would have symptoms of bradycardia. The patient would be having an altered mental status. He would be or she would be hypotensive. So we should take that seriously. We should push the patient to a resuscitation room, and because of there's a huge differential in involving hypotension and bradycardia and even hypothermia. But if the patient has history of thyroid disorders or hypothyroidism in general, specifically, we should always keep that in mind. So the reason why it used to be called myxedema coma because of the altered mental status that the patient would present. And the reason why the patient would have an altered mental status, it's either from the carbon dioxide narcosis due to the hypoventilation that the patient would present in, or from hypoglycemia due to decreased gluconeogenesis and decreased insulin clearance that is caused by the decreased levels of thyroid hormone. Okay, what are the precipitants of myxedema crisis? So infection is one of the most common causes in any hypothyroid patient. Cold exposure, which we don't see here, very common in our country. History of trauma, myocardial infarction, congestive heart failure, GI hemorrhage, recent surgery, or medications. One of the medications that could cause this myxedema coma or thyroid disorders in general is amiodarone, and amiodarone is almost widely available in every ER department, and it's used for different arrhythmia as a management for arrhythmia. But a lot of people do not know that it contains a high level of iodine, which will mix up everything for the thyroid patient. So how can we diagnose a patient? So unlike just simple hypothyroidism, we have hypothermia, which is almost always there. It would be about 33 degrees Celsius or less. Hypotension or profound hypotension. So the patient's mean arterial pressure will be less than 65. Patient would have bradycardia, and you would see this patient's breathing would be slow, deep, and shallow, and he will be in, or she would be in hypoventilation. So supportive treatment means we're just going to maintain the airway, breathing and circulation, giving IV fluids, correcting any electrolyte abnormalities, and we should always find the cause of this condition. So infection has to be in the back of your mind at all times, and we should consult the endocrinologist and start immediate thyroid hormone replacement therapy. The difference between hypothyroidism in general and myxedema crisis, that it is a clinic, the myxedema crisis is a clinical diagnosis. You do not and cannot wait for the lab test to occur. TSH and T3, T4 would usually take 3 to 4 hours to appear in the ER. It would be too late to intervene if the patient's already coming in a bad state. So you have to treat them immediately, especially if you have history of hypothyroidism. How can we treat the hypothermia? We have methods of passive rewarming, which means we can use some kind of blankets or warming blankets. The most common one used everywhere is called a bear hugger. This would definitely help the patient regain the normal temperature. Vasopressors, if indicated, if the patient is hypotensive and is not responding to fluid resuscitation, then you definitely need to start vasopressors. The best vasopressor to be used in any condition is norepinephrine. Water restriction for hyponatremia, if the patient is hyponatremic, then you definitely should restrict the patient from water. Steroids, you should give hydrocortisone in high doses, up 1 to 200 milligrams IV. And the reason why we're treating myxedema crisis with hydrocortisone, if we do not give hydrocortisone prior to the thyroid replacement therapy, is this patient could have an underlying masked adrenal crisis going on. So without giving the hydrocortisone, you would start treating the myxedema crisis, and then you would be in a very bad situation when you realize that you have a patient with also has adrenal insufficiency and went into adrenal crisis and would be refractory to giving the vasopressors. So when we come and talk about thyroid replacement therapy, we are going to talk about two forms of medications. Most commonly is IV thyroxine, which is T4. The synthetic form is levothyroxine, which is widely available everywhere. Initial dose should be of 4 milligrams per kilograms IV. So a dose between 200 and 400 milligrams would be sufficient. Special considerations, as we mentioned before, in elderly and cardiac patients should have a lower dose. The other medication that could be used is IV triiodothyronine, which is the leothyronin, which is the active form of the thyroid hormone. We can use a loading dose of 20 mics IV, and then we have a maintenance dose of 10 mics every 8 hours. But let's compare both medications and see what are the benefits and disadvantages of each. So when we're talking about levothyroxine, it is a steady and slow onset, and as we said, it's widely available everywhere. Already in an active form, okay, and it's okay. The disadvantages of levothyroxine are decreased extrathyroidal conversion of T4 to T3 during the crisis. Basically, the active form of the thyroid hormone is the T3, which is triiodothyronine. This is only produced in the body about 20% from the thyroid gland, and the rest of the 80% is converted from T4, which is thyroxine, into the T3 form, which is free and not bound to albumin and or proteins, and will be actively metabolized throughout the peripheral cells. So this is the only disadvantage of levothyroxine. It will take a longer time to be activated. However, because of the T3 is already in active form, which is one of the advantages, and its rapid onset, and it could cross the blood-brain barrier. But as a disadvantage, because of its potency and fluctuation in the serum level, it could lead to cardiac dysrhythmias. So the patient is already in shock, and he's hypotensive and bradycardic, and you give something like that, that could lead to major complications. So definitely just go with levothyroxine. Okay. So the final step in management should be identifying and managing the cause of infections. We should start broad spectrum antibiotics, any kind of medications, whether we're talking about sedatives or beta blocking agents or other antiarrhythmic medications, should be stopped immediately. Cold exposure, we already said we would rewarm this patient. Trauma patients should be managed as soon as possible, as in the OR if needed. Myocardial infarction, you should have the cardiologist on call with you. Congestive heart failure, if the patient is having pulmonary edema, you should put the patient on BiPAP and start tridyl infusion. And you could even give furosemide to decrease the fluid, to excrete fluid from the patient. CVA, if the patient has symptoms of stroke, you should definitely have a higher suspicion rate in these cases, and also have a CT as soon as possible. GI bleed, you should consult GI on call as soon as possible. Hypoxia would be treating it by giving high flow oxygen through a non-rebreather mask. Hypercapnia could be dealt with either with the oxygenation or with positive pressure ventilation. Hyponatremia, we could treat it. It depends on the level of the hyponatremia. If it's lower than 110, then you should give, or you should consult ICU even to be on board to give hypertonic saline. And hypoglycemia, we would be treating it with dextrose. So where is this patient going to go? Definitely the patient will be admitted to the ICU, and then they will start managing the patient there, and then they might downgrade the patient to an inpatient facility if the patient responds to the management. So that was the first part of our thyroid discussion. Second part would be about hyperthyroidism or thyrotoxicosis. Both terms are interchangeable. It means the same thing. We have excessive amount of thyroid hormones, which are T3 and T4, circulating the body. And what that leads to is an increased metabolic rate, increased heart rate, increased ventricular contractility, and increased muscle and CNS excitability. So these patients usually have signs and symptoms of nervousness, irritability, increased resting heart rate. Patients would always complain about palpitations, heat intolerance. They are always known to have a huge appetite, but they're always losing weight. Frequent bowel motions, thyroid enlargement. The patient could present with goiter. Um, and females would present with menstrual disturbances as well. Insomnia is a common symptom, and when we're talking about Graves' disease, we have eye or ophthalmology symptoms, which are decrease in visions, eye irritation, and exophthalmos. Um, but that's only in Graves' disease, which is the most common cause of hyperthyroidism, consisting of 85% of all cases. The second most common cause of hyperthyroidism is toxic multinodular goiter. And then we have the toxic nodular adenoma, which is a single hot nodule producing elevated thyroid gland hormones. Thyroiditis, as in Hashimoto's thyroiditis, is inflammation of the gland, which also could lead to hyperthyroidism. But in Hashimoto's thyroiditis, that would be in the initial phase, which the patient would present with hyperthyroidism, and then typically followed by a state of hypothyroidism. Secondary hypothyroidism is a thyrotropin secreting pituitary adenoma, which would affect the thyroid to produce more hormones, leading to hyperthyroidism. So, how would we diagnose a patient with hyperthyroidism? Usually, as the same as hypothyroidism, they're not usually diagnosed in the ER. However, if they are seeking medical attention and they do not or were not diagnosed previously with thyrotoxicosis, we could order these labs for the patient, and within the management time, we could diagnose these patients. So the lab testing would be the same: CBCs, UNEs, random blood sugars, renal and liver function tests, serum cortisol, and we should always obtain an ECG because patients with thyroid disorders are always known to have arrhythmias, especially atrial fibrillation, and chest X-ray just to rule out any infection causing the patient's symptoms. In the TSH, T4, and T3 levels. And hyperthyroidism would be the exact opposite of hypothyroidism. So the TSH would be in a low level, and free T4 and T3 are elevated. In some patients, about 5% of them would have something called T3 thyrotoxicosis, which means the T4 level would be normal. You would have a low TSH, but an elevated T3 hormone. For simple thyrotoxicosis cases, also, we are just going to give the patient supportive care. It's going to be symptomatic treatment, and we should urge everybody to send these patients urgently to an endocrinologist or their primary health care provider as soon as possible. It's preferably within 1 week or 2 weeks of the ER visit. The dangerous form of thyrotoxicosis is the thyroid storm. It's a clinical diagnosis, same as myxedema coma. We do not rely on lab testing for these kinds of patients. The patient is known to have thyrotoxicosis most of the time, and management of these patients is in a stepwise uh, kind of protocol that we always have to follow, and I will be explaining these in a while for you. So what are the symptoms and signs of thyrotoxicosis? The patient would have hyperthyroidism symptoms as well as a more profound hyperthermia, usually about 40 or 41 degrees Celsius. In cardiovascular symptoms, the patient would have tachycardia, pedal edema or pulmonary edema, atrial fibrillation, and basal crepitations from the fluid overload. CNS symptoms would be agitation, delirium, psychosis, seizures, and possibly even coma. Gastrointestinal and hepatic symptoms, patients would come with nausea, vomiting, diarrhea, abdominal pain, and jaundice. So, what is the pathophysiology of this issue? With increased levels of thyroid hormone, we would have increased adrenergic activity, leading to more release of thyroid hormone and receptor sensitivity, which would mean elevated serum levels of T3 and T4. When the precipitant, or such as infection, MI, or any cause that could lead to this thyroid storm, any insult to this patient, then the effect of T4 and T3 is like magnitude um, 10 times more than the normal hyperthyroidism. So the effects are going to be extremely profound, which explains why the patient is extremely hyperthermic, tachycardic, delirious, and agitated, and possibly entering in seizures and coma. So these are the precipitants of thyroid storm, infection, one of the most common causes, trauma, general surgery recently, endocrine insults such as diabetic ketoacidosis or hypoosmolar hyperglycemic states, drug or hormone related in patients who have iodine administration for any reason, thyroid gland maneuver or palpation, or accidental or intentional ingestion of thyroid hormone would also cause thyroid storm. Cardiovascular insults such as myocardial infarction, cerebral vascular accidents, and pulmonary embolism. Obstetrics related, that would be in eclampsia and labor and delivery. Patients who are receiving radioiodine therapy could have a thyroid storm. And up to 25% of these cases, we do not know what the cause is. So as we mentioned before, we were not going to wait for a TSH, T3, T4 level. The patient should be diagnosed clinically. Any patient with history of hyperthyroidism with symptoms that we mentioned, especially hyperthermia, tachycardia, and altered mental status, you should start managing this patient as a thyroid storm patient. Management, it's a 5-step management plan. In other sources, they mentioned it's a 7 or 8-step management plan, but the main steps are 5. In suspected female patients, a pregnancy test is mandatory prior to initiation of the management protocol, and we will be discussing that in a while. So basically, in summary, uh, these are the main steps of treating a patient in thyroid storm. Step 1 is giving beta blockers. Step 2 is giving uh, propylthiouracil or methimazole. Number 3 is iodine replacement, and number 4 is steroids, and number 5 would be um, uh, supportive care. However, I think supportive care always has to come as an emergency physician as number 1. Any patient that comes in the ER with symptoms of hypotension or hypertension, tachycardia, and everything, you will always assess the patient ABC in the beginning. But in the textbooks, they would mention it as number 5 because of because they're focusing on giving the beta blockers first to the patient. So Why would we give blockers in patients with thyroid storm? Because we're trying to inhibit the peripheral adrenergic effects. Patients who have severe tachycardia and patients who are known to have AF are risky. So giving beta blocker actually has a double action, which number one would be inhibiting the tachycardia that's going on, and it would be also inhibiting the peripheral conversion of T4 to T3 to its active form, basically. So the drug of choice in thyroid storm beta blockers is propanolol. The dose is 1 milligrams every 15 minutes if the patient cannot tolerate oral medications, and most of them don't. If the patient can tolerate orally, you can give 60 milligrams of propanolol every 6 hours. Um, the goal of therapy is reaching a normal heart rate, which is below 100 beats per minute. Step two of managing thyroid storm patients is inhibiting new thyroid hormone synthesis and production. These medications are collectively called thionamides. So methimazole and PTU are both thionamides who have different mechanisms of action and also different reactions to the patient. So when we're talking about methimazole as a drug of choice. This is because sometimes it's going to take a long time before you establish if whether this female patient, if it was a female patient, was pregnant or not, because PTU is a teratogenic drug and should not be given in any patient during the first trimester. So methimazole is the safe route for for these patients. The dose is usually 30 milligrams orally every 6 hours. Um, it's um, it's a free form in the serum. It could be given orally, intranasally, or per rectum. The second drug is propylthiouracil, PTU. The dose is usually 5 to 1,000 milligrams orally as a loading dose, and then followed by 250 milligrams orally every 4 hours. Number three is inhibition of T4 and T3 release. This step should be started at least 1 hour after thionamides because these medications are iodine-based medications. In patients who have thyroid storm, if you give a patient with thyroid storm iodine-containing medications, it would increase the production of T3 and T4 in the body. So basically, what you're doing is harming the patient even more. So you need to give the thionamides time to act on the patient. So at least an hour until you start giving one of these medications. The medications that are available is iodine Lugol solution, which is given in 5 drops, either orally through NGT or rectally every 6 hours. Another alternative is potassium iodide. 1 to 2 drops should be sufficient every 6 hours. Each drop contains about 50 milligrams of potassium iodide. And in patients who are or have allergies to iodine or are contraindicated to be receiving iodine, you can use lithium. The lithium dose is 300 milligrams PO and NG through a nasogastric tube, but you should never give lithium in a pregnant lady because of the teratogenic effects it has on the baby. Number four, inhibition of hormone release. As we mentioned before, that 85% of the T3 that's circulating the body comes from peripheral conversion of T4. To inhibit this, we're giving 3 different agents to inhibit the conversion of T4 to T3. We've already established that we've given propanolol, which has a double effect as a beta blocker, and it will prevent the conversion of T4 to T3. If you're using PTU, that would have also a double effect, which is not seen in methimazole. And glucocorticoids would do the same effect on the prevention of peripheral conversion. So we're going to give a high dose of hydrocortisone, which is about 300 milligrams as a bolus, and then we would give 100 milligrams every 8 hours until this patient becomes stable. So, supportive care, airway, breathing, circulation, maintain all three. Patients who are hyperthermic, we would start giving external cooling methods, which are giving ice packs in the axilla and between the thighs and below the knees. We would use cooling blankets for these patients. We could use cold saline around 4 degrees centigrade. And the best medication to give in a thyroid storm is acetaminophen. Do not give aspirin or NSAIDs in patients with thyroid storm. For dehydration, we would restore IV fluids. Usually normal saline would be sufficient. If the patient is hypoglycemic, then we should definitely switch to a dextrose containing solution. If the patient is agitated and is not comfortable and it's difficult, he or she is difficult to manage, benzodiazepine is an excellent choice for agitated patients to be treated easily in the ER. After the patient is starting to get out of the thyroid storm, patients should definitely be admitted in an intensive care unit facility. And once the patient is completely out of thyroid storm, patients should have definitive therapy, either radioiodine ablation or surgery to remove the thyroid gland. I see that there is a question. Dr. Ahmed. تفضل دكتور أحمد.
Well done, continue, nothing.
طيب اوكي يعطيك العافية.
Sorry for that.
Okay. So that was our topic about thyroid disorders. In general, we were talking about hypothyroidism with myxedema coma as a serious complications, hyperthyroidism in general with thyroid storm as a serious and life-threatening complication. If you have any questions regarding thyroids, I would give you guys like a couple of minutes if you need any questions regarding this part of the lecture. If not, we could continue to the adrenal insufficiency and adrenal crisis. Okay, so question number one, Dr. Amjad said, is it common to have hypothyroidism with adrenal insufficiency? The answer is it's not as common as you shouldn't have both at the same time usually, but it could happen. And the only way we could even know if the patient has adrenal insufficiency with hypothyroidism, if we order a serum cortisol from the beginning, or if we go into that crisis that we do not want to go in, is treating the hypothyroidism and not giving the steroids, hydrocortisone. Then it would unmask the adrenal insufficiency. And in regards to the part of adrenal insufficiency and crisis, which we'll be talking about in a while, I'll be mentioning why. Okay, so question number two, iodine administration can cause myxedema crisis and also thyroid storm. Iodine administration should cause thyroid storm. I might have mixed up and said it could cause a myxedema crisis, but it's mainly about thyroid storm because of the iodine-containing medications that are being received by the patient would lead to increased synthesis of T3 and T4 in the body. Okay, which thionamide is safe in pregnancy? I've already mentioned that methimazole is the choice of medication in pregnant patients. Just hold on with me. Okay. So I've mentioned earlier that methimazole is the safe choice. So I'm sorry, that was my mistake. It's actually contraindicated in pregnancy. So you should not give patients who are pregnant methimazole. It's classified as category D for teratogenic effects. Carbimazole is a alternative, but I'm not really sure if it's safe in pregnancy or not. But if the patient is pregnant, then you should switch to propylthiouracil. As an amiodarone, high level of iodine for myxedema crisis and drug induction thyroid storm. Iodine, I did not understand your question, Yasara. Which thiamide is safe? Okay, we've already answered that one. How can I catch the symptoms of thyroid problems? Because of patients who have thyroid issues have a wide variety of a wide variety of symptoms. There isn't actually something specific, but if you have a high clinical sense and you have a wide, broad differential of causes that the patient's symptoms could explain, and you're starting to rule them out. So maybe in an ER setting, that would be a diagnosis of exclusion. I've never seen anybody diagnose a thyroid patient in the ER. Only I've read it in books. Usually they're already diagnosed outside, either in clinics, whether they're private or in the same hospital, or when they are admitted as inpatients with the medical workup. During the admission, they could have find or do some workup for the thyroid disorders, and that's when they diagnose a patient with thyroid problems. However, if you start excluding the causes of these symptoms that the patient have, and nothing makes sense, and thyroid disorders make sense, then if you have time and the ER isn't busy and the patient is still there or is going to be admitted, just order the thyroid function tests and you can follow that up after 3 or 4 hours, even after admission. Okay, there's a question about anti-TPO antibiotic significance. What kind of antibiotics are we talking about? Anti-TPO? Hold on. You're talking about the anti-thyroid antibodies, antibiotics? I'm not sure I follow your question. Okay, what I meant is amiodarone with high iodine causes myxedema and drug-induced storm. Of them is iodine. So iodine can cause both. No, iodine would cause a thyroid storm. I misspoke when I mentioned it causes myxedema. It would cause hyperthyroidism, and in a patient who was already in an established thyroid storm, that could make the patient worse. Antithyroglobulin antibodies are tests that are done specifically for Graves' disease. So they have actually no role in the ER. Um, they wouldn't add any clinical significance in emergency care. It could have clinical significance in the clinic, of course, or inpatient, admitted inpatient management. But in the ER, it really is a limited and not usually ordered lab test. Okay. Okay, let's move on to adrenal insufficiency and adrenal crisis. So, okay, so the adrenal gland, it synthesizes steroid hormones in its cortex and its medulla. The cortex would have some kinds of different hormones that we would mention. Um, the first one is one of the mineralocorticoids, which is aldosterone, which regulates the mineral and water balance in the body. Glucocorticoids, which regulates glucose metabolism in the body, and the main example is cortisol. And the sex or androgen hormones are also developed and secreted by the adrenal gland. Uh, the medulla itself would be secreting catecholamines, which is epinephrine and norepinephrine. Um, Almost as the same as thyroid disorders, we would have primary, secondary, and tertiary causes of adrenal insufficiency. Primary adrenal insufficiency means the gland itself, the adrenal gland, would have an issue with secreting these hormones. Um, we would have decreased cortisol, aldosterone, and gonadotropins, but this only occurs when 90% or more of the gland is destructed. It's also called Addison's disease. So as we mentioned, the adrenal gland is not producing sufficient amounts of steroids. Patients, one of the known symptoms or signs of patients with Addison's disease would be skin hyperpigmentation, low blood pressure, weakness, and weight loss are symptoms of the patient participants. And gastrointestinal symptoms would be nausea, diarrhea, vomiting, constipation, and abdominal pain. Skin, besides hyperpigmentation, patients also could have vitiligo. In adrenal crisis, in addition to these symptoms, we would have more serious symptoms, which is fever, syncope, convulsions, hypoglycemia, hyponatremia, and severe vomiting and diarrhea. Secondary adrenal insufficiency, which means there is a hypothalamic pituitary dysfunction, and the patient, this dysfunction would lead to failure to secrete the ACTH and also the CRH hormones, which would lead to decreasing cortisol, but the rest of the gland or the rest of the adrenal gland should function normally. So that means normal levels of the aldosterone and normal levels of gonadotropins. So this is the axis of the hypothalamic pituitary axis, where we have stress that causes activation of the hypothalamus, which would release the CRH, which is corticotropin releasing hormone, which activates the anterior pituitary to release ACTH, which is adrenocorticotropic hormone. And that in itself would lead to activation of the adrenal gland and to secrete the cortisol and other hormones. However, cortisol is the most important one when it comes to the negative feedback mechanism that we're talking about here. So it would inhibit the pituitary and hypothalamus and then decrease the secretion, and it will maintain its homeostasis in that way. So primary adrenal insufficiency, then this is where we will have the issue in the adrenal gland. Secondary and tertiary would be adrenal and pituitary respectively. Causes of primary adrenal insufficiency are a very wide variety. We would start with autoimmune, which is a polyglandular autoimmune syndrome. Adrenal hemorrhage, this is an acute cause of adrenal insufficiency. Patients would have necrosis from meningococcal sepsis or coagulation disorder, or from a syndrome which is called Waterhouse-Friderichsen syndrome, which is overwhelming sepsis leading to acute hemorrhage or thrombosis of the adrenal gland. Medications, etomidate, which is the most commonly used sedative agent in rapid sequence intubation. It's used in about 80% of intubation worldwide. So this is one of the topics that we'll be talking later on about. Um, Ketoconazole is one of the drugs that could cause adrenal insufficiency as well. Infections such as TB, fungal infections, sepsis, infiltrative disorders such as sarcoidosis, amyloidosis, and lymphoma. Surgery, patients who have received bariatric surgery or bilateral adrenalectomy would go into adrenal insufficiency. Hereditary would be adrenal hypoplasia, congenital adrenal hyperplasia, and familial glucocorticoid deficiency. In secondary adrenal insufficiency, the most common cause would be prolonged steroid therapy. Patients who are chronic users of steroid have inhibition of the CRH and ACTH production. So the gland itself does not have any issue, but because of these steroids, we have chronic inhibition of CRH and ACTH, which would eventually lead to adrenal insufficiency. Pituitary necrosis or bleeding, this is called the Sheehan syndrome, which is postpartum pituitary necrosis. Any kind of brain tumor could cause this. Pituitary radiation surgery or head trauma could also cause secondary adrenal insufficiency. Infiltrative disorders such as sarcoidosis, hemochromatosis, lymphomas, and hemosidrosis, and CNS infection involving hypothalamus, such as TB, meningitis, and HIV or fungal infection. Features of primary and secondary insufficiency. So patients who have these deficient hormones would present in the ER with different or variety of symptoms. Volume depletion and hypotension is severely seen in primary adrenal insufficiency. In secondary, which would not be as severe unless the crisis is present. Serum potassium, patients in primary adrenal insufficiency would be hyperkalemic, where will they be hypokalemic in secondary causes. Serum sodium is the opposite. It would be hyponatremic in primary and hypernatremic in secondary, because the aldosterone is present, and uh, hyponatremia could be developed if this patient has a water retention. So it could be both, but most likely it would be hypernatremia. Cushinite appearance could be seen in secondary patients due to the long-term use of glucocorticoids. Symptoms of either pituitary hormones or deficiencies, we're talking about hypothyroidism and amenorrhea. Uh, it's not really seen in primary adrenal insufficiency, and it could be present in secondary adrenal insufficiency. Skin pigmentation is present in primary due to the high ACTH level and is absent in the secondary. Glucose is usually low in both, and cortisol is also low in both, while the ACTH would be high in primary and low in secondary adrenal insufficiency. So, what are the labs that we should order for patients who are suspected to have insufficiency? Same as any other patients, would be ordering CBCs, random blood sugar, calcium, urine, and electrolytes to monitor the sodium and potassium. Serum cortisol should be ordered for these kind of patient. If it's above the level of 18, that rules out any adrenal insufficiency. It's not commonly ordered as a routine lab test for other patients, but if you're suspecting adrenal insufficiency, you should definitely order that. ECGs and chest X-ray as well. If you are suspecting a patient who is coming in an adrenal crisis, and it's acute, then you should do an abdominal CT and a brain CT. To just for abdominal CT, we're looking for adrenal gland hemorrhage or infarction. In CT brain, we're looking for secondary causes of adrenal insufficiency. So patients who come in primary or secondary insufficiency are managed in the ER as any other patients. We would be giving supportive care. If the patient is diagnosed as primary insufficiency, then they have, because of the defects that they have in aldosterone, cortisol, and gonadotropins, then they might need to be put on mineralocorticoids and also glucocorticoids for life. But in secondary causes, the only deficiency would be in cortisol. So the patients would only need glucocorticoids. Adrenal crisis is a life-threatening state of insufficient levels of cortisol, characterized by severe hypotension. So patients, usually when you're seeing patients in the ER and you see hypotension, first thing that comes up that this patient has some type of shock, and most common type of shock could be septic shock or hemorrhagic shock. But these patients have something that are different from other types of shock, which is they would not improve on vasopressors, unlike other types of shock. So other characteristics of these patients would come with severe abdominal pain, severe nausea and vomiting, mimicking acute abdomen or diabetic ketoacidosis. CNS manifestations are confusion, disorientation, and lethargy. And patients could develop sepsis without developing a fever in adrenal crisis. Management-wise, adrenal crisis should be treated as a septic shock patient or any type of shock patient. So first of all, we're going to give IV fluids. We're going to use 2 large bore IV lines in the antecubital areas of the both arms, and we're just going to give 1 to 2 liters boluses for these kinds of patients, and we're going to reassess and reevaluate for the hypotension and the hydration status. However, if the patient is hypoglycemic, then you should definitely start with D5 normal saline instead of normal saline. Second line of management, we should give steroids to get the patient out of the crisis that they're in. So we're going to start with hydrocortisone. A usual dose should be an 100 milligrams IV bolus. And this is the drug of choice in these kinds of patients, because we need glucocorticoids, and hydrocortisone is the best choice for these patients. So if we don't have an IV line, what can we do? We can give hydrocortisone intramuscularly. After that, we can start an IV infusion of 200 milligrams every 24 hours or 100 milligrams every 6 hours. But we also have to consult ICU and endocrinology regarding these patients and the dosage of the medications that they want to give. An alternative is dexamethasone, which would be 4 milligrams as a bolus. However, most textbooks recommend that you always have to start with hydrocortisone, and I don't think that any hospital anywhere does not have hydrocortisone in their pharmacy. Supportive care should come always first. ABCs, make sure the airway is okay and maintained, breathing and oxygenation is okay, connect the patient to cardiac monitors and order an ECG. And if the patient is tachycardic, we'll see if the patient will improve with fluid resuscitation or not. Vasopressors, as we mentioned, that would not be working in these kinds of patients initially, but you can only administer it after giving steroid therapy. This is the reason why vasopressors would not work in adrenal crisis. Okay. Next step in management, once the patient is starting to become stable, you should definitely look for the underlying cause. As we mentioned, sepsis is one of the most common causes. Adrenal hemorrhage, sinus abnormalities. We'll be doing CT brain for the patient, CT abdomen, chest x-rays, different kinds of labs, and trying to find what caused this patient to go into adrenal crisis. Optimizing and maintaining dose of steroids would not be done in an ER department. Usually it would be after during the hospital course of this patient. All adrenal crisis patients should be definitely admitted into intensive care unit for further management. I've mentioned before that the etomidate is the most commonly used sedative in the ER. There's always debate between us in the ER and between intensivists in the ICU in patients who receive etomidate who are suspected to be septic. A lot of research has been done about etomidate and the issues regarding adrenal insufficiency. By theory, the ICU doctors usually do not prefer etomidate as theoretically it could lead to acute adrenal insufficiency. However, the number of studies that were done were about 5 studies, and most of them were retrospective, and it only mentioned multiple doses of etomidate. In ER setting researches, a single dose of etomidate was shown that it would not increase any mortality in patients with sepsis. So if you are in the ER and you need to intubate a patient and you have a septic patient that needs intubation, do not bypass etomidate and choose another sedative just because you are afraid of adrenal insufficiency. That would not happen. It's just theoretical. Theoretical. It's not. It does not happen. Okay, let's try to summarize both the thyroid and adrenal insufficiency in key points. Hyperthyroidism, thyroid hormones that are elevated in the patient. T3 and T4 are elevated in these patients, and TSH are low. Lab tests are not a mainstay treatment in the emergency department. You could do them for stable patients. However, if the patient is critically ill and you think that this patient has a thyroid storm, do not wait for the lab results and start management immediately. We're going to start with giving beta blockers, which is propranolol, and then we're giving a thionamide, with, whether it is PTU or methimazole. We're going to wait 1 hour until we give an iodine replacement therapy. After that, we would give a hydrocortisone, and finally supportive care. In hypothyroidism, we're talking about low levels of T3 and T4 circulating the body. The most common, or sorry, the most serious form of hypothyroidism would be Myxedema crisis. Replacement of the thyroid hormone should be done in the emergency setting. The best choice would be levothyroxine, which is T4. And both thyroid storm, thyrotoxicosis, thyroid storm, and myxedema coma should be admitted in an ICU setting. For adrenal insufficiency, whether it's primary or secondary adrenal insufficiency, they have vague, non-specific symptoms and are not really serious until they become in critical condition in adrenal crisis. Once you suspect adrenal crisis, make sure you follow the management in a stepwise fashion. You always have to give hydrocortisone. You have to fill this patient with fluid, and then if needed, you can start pressors. But if you start pressors without giving hydrocortisone, the patient would be hypotensive and will remain hypotensive. So we're already finished about half of the lecture. I think it's beneficial for everyone if we take a 5-minute break, clear your mind, stretch your legs, go eat something or drink something, and we'll start in 5 minutes, inshallah.
طيب الله يعطيك العافية دكتور أحمد. خلاص حول يعني 5 minutes وإن شاء الله نرجع مرة ثانية بإذن الله.
خلاص إن شاء الله على خير. طيب بسم الله، جاهزين نبدأ الجزء الأخير Diabetic Emergencies.
ايوه تفضل دكتور احمد.
So diabetic emergencies, diabetes is a very, very common disease worldwide. Unfortunately, in Saudi Arabia, it's increasing year after year. We are around 40% or more of patients who are obese and above the age of 40 are experiencing some types of diabetes type 2, which is very concerning to see, and the big variety of complications that lead to DKA and HHS, and even other complications such as diabetic foot and diabetic foot infections. Today we're going to talk about hypoglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic state. We're going to start with hypoglycemia. So hypoglycemia is a common thing to see in the emergency department. Patients who are not known to have diabetes, to be clinically defined as hypoglycemia, is one, patient presents with symptoms of hypoglycemia. Number two, they would present with low serum glucose levels. And if you treat the hypoglycemia, patients' symptoms would resolve. In diabetic patients or patients known to be diabetic on medications, a plasma glucose of less than 70 milligrams per deciliter, which is equivalent to 3.9 millimole per liter, should diagnose hypoglycemia. Random blood sugar is considered in the emergency department one of the 6 vital signs. So we're talking about heart rate, blood pressure, temperature, and oxygen saturation. Then most patients need to have a random blood sugar done in the ER, especially if they are presenting in altered mental status, seizures, or loss of consciousness. All of these are causes of one of the different major differentials is hypoglycemia, and it's easily treatable. And if you don't look for it, you will definitely miss it. These are the differential diagnoses of hypoglycemia: acute stroke, transient ischemic attack, seizure disorder, traumatic head injury, brain tumor, narcolepsy, multiple sclerosis, acute psychosis, sympathomimetic drug ingestion, hysteria, altered sleep patterns and nightmares, and depression. Symptoms of hypoglycemia: patients would come diaphoretic, they would be sweating, pale, irritable, dizzy, they would have lack of concentration, they would be drowsy or sleepy, and they would be hungry. How to diagnose it? We are just going to do the random blood sugar, whether in the triage or while trying to resuscitate the patient. You should always obtain a random blood glucose. And as we mentioned, if the level is below 3.9 millimoles, then that's the definition of hypoglycemia. How to manage a patient in hypoglycemia? The mainstay of treatment is IV glucose, which is IV dextrose. We have different types of fluid formulas for dextrose, but usually these come in small ampules of which are called B50 and 50 ml formulas, which contain 25 grams, or which is equivalent to 100 calories of glucose. Usually, patients would start waking up and their symptoms would go away from one single dose. But if the patient is still hypoglycemic, when you repeat the blood sugar, you can give another or third dose and see. If the patient does not improve, then there's some kind of insult that's going on in the body that would prevent this patient from retaining normal glucose level. In patients who have difficult, we see this all the time in the ER. We could not establish an IV line. You do not have an interosseous line, and the patient is almost comatose. Then you try to intervene. An alternative to dextrose is intramuscular glucagon. It's readily available in every emergency department. It comes as a single syringe that would be given to the patient, and it would have the same effects almost as the 50. Octreotide is a medication that is usually used in other types of situations such as GI bleeding, but because of its a somatostatin, its release inhibits insulin release. These are given in patients who are on sulfonylurea medications, who either have intentional or unintentional overdose. One of the management lines is resume oral intake as soon as possible. And when we talk about oral intake, it doesn't mean I need just to give him something sweet and just a simple piece of sugar or just a bar of candy. No, we would prefer complex carbohydrates and proteins for these kinds of patients, because we're talking about long-term normal glycemia. If you give them just a simple dose of D50 and some kind of candy, patients could develop another bout of hypoglycemia as soon as they are discharged or even before discharge. So hypoglycemia is a simple thing to manage. It's a simple thing to look for. There's really no discussion in hypoglycemia. As long as you don't miss it, then you're being on the safe side, and you could have literally saved a patient life. Let's talk about the more common or the more, serious conditions. Number one is diabetic ketoacidosis. From its name, we would derive that this patient has diabetes, which should have elevated levels of serum glucose. Ketoacidosis, so keto is ketosis. Patient would have developed ketone bodies in the body, and to be circulating in serum and also in urine. Acidosis, which is a high anion gap metabolic acidosis seen in all DKA patients. It is a life-threatening complication of diabetes, predominantly type 1. That does not mean, and we would not see a patient who was type 2 on oral hypoglycemic that could cause a come in DKA. So always any kind of patient, whether it's type 1 or type 2, you should be vigilant about DKA. So if you're seeing a patient in triage, this is a typical scenario. Usually you have a patient who is coming into the ER, and the patient looks sick. They have abdominal pain, they're vomiting, they don't feel well, and you ask them if you're diabetic or not, and they say yes, and they have an elevated blood glucose level. You should obtain a VBG, and we'll discuss the details about that later. But you can diagnose a DKA in triage, and then push the patient to a resuscitation room and start managing this patient. What happens in a patient in DKA, because of the insulin deficiency that's going on, the patient would have something called cellular underutilization of glucose and also increased hepatic gluconeogenesis. Both would lead to hyperglycemia. So that's the first part of DKA. Hyperglycemia would increase glucosuria and osmotic diuresis. This is the issue where a lot of people have a difficult time to understand. But if you have osmotic diuresis, you are losing sodium chloride, phosphates, potassium, calcium, magnesium. So you have electrolyte disturbances, hyperglycemia, and you're losing fluids as well. The patient becomes severely dehydrated. So you have a difficult type of situation that you need to maintain and follow up and continuously monitor. So osmotic diuresis would lead to decreased GFR, the glomerular filtration rate, which would cause severe hypoglycemia, leading to dehydration and hemoconcentration, which could lead to a shock. It would also cause intracellular dehydration and would lead to impaired consciousness of the patient. Another reaction from the insulin deficiency would be lipolysis. Lipolysis would lead to free fatty acid transportation to the hepatocytes. After that, it's taken to the hepatic mitochondria, where it's metabolized by beta oxidation into keto acids. So we would have ketonuria and the high anion gap metabolic acidosis because of all the ketone acids that are circulating the body. And ketoacidosis also leads to vomiting, which goes back to dehydration, such as the high anion gap with compensatory tachypnea would lead to dehydration and eventually shock. So we want to try and manage the patient in the early phases of hyperglycemia and dehydration and ketosis before the patient enters into severe acidosis or shock. Causes of diabetic ketoacidosis. The most common cause would be in type 1 diabetic patients, if patient missed their insulin dose, whether it was intentional or not. If the patient is on insulin pump catheter management, if it's a dislodged catheter or an occluded catheter, that means the patient would not be receiving their insulin, and it would also lead to DKA. Infection is a very, very common cause in patients who are diabetic and on insulin. If you ask them if they took their last insulin dose, they would say yes, but they would present with symptoms of infection. So you definitely have to find the source and treat it as soon as possible. Pregnancy, hyperthyroidism, pheochromocytoma, and Cushing syndrome could cause that. DKA, the substance abuse such as cocaine would also lead to DKA in some patients who are diabetic. Medications such as steroids, antipsychotics, sympathomimetic, heat-related illness, CVA, MI, GI hemorrhage, pulmonary embolism, pancreatitis, major trauma, or surgery. So you have a very wide variety of causes that could lead entering a patient's diabetic ketoacidosis. You would eventually have to rule out which of these caused it, but the main focus here is really on how to manage these patients. So the clinical features are the same as any diabetic patients, polydipsia, polyphagia, and polyuria. So patients would come thirsty and they're drinking huge amounts of water, but they're also losing huge amounts of water. Polyuria, patients would be losing their water through urination. Patients would have nausea and vomiting as well. But instead of just hyperglycemia, when the patient has acidosis and ketosis as well, you would have a low GCS score due to the confusion. You could identify a ketotic breath while evaluating the patient. Kuzmal breathing is a mechanism that the body is trying to compensate the acidosis that's going on. So what the body is trying to do is trying to wash out the CO2 as much as possible to try to enter these into a respiratory alkalosis, trying to counteract the metabolic acidosis. So this is typically seen in patients with DKA, deep, shallow, prolonged breathing, especially in the expiration phase of the breathing. So patients are getting rid of the CO2 to maintain a better pH level. Eventually, the lung would give out and not be able to do such a thing, and the patient would become severely acidotic and could possibly die. Tachycardia, hypotension, and dehydration could be seen in these patients, and these are the critical DKA patients that you want to treat immediately. So lab testing, a lot of labs have to be ordered, of course, to rule out the main cause of the DKA, but the most two important tests that you would be doing is random blood sugar while assessing the vital sign and obtaining venous blood gas. So typically, we would see elevated glucose in diabetic ketoacidosis levels above 350 milligram per deciliter. Sodium would be low most in patients who are losing sodium. Potassium is not the levels that you would see in a VBG or even in serum levels are not the true potassium levels in the body due to the acidosis and the insulin, because of the actions of insulin that would be done during the treatment, which would mask the true level of potassium in the body. Bicarb definitely would be low. We're talking about high anion gap metabolic acidosis. Blood urine nitrogen is part of the urine electrolyte workup. It would usually be between 25 and 50. And serum ketones, if you order it in the ER, then it will definitely be present. So managing a diabetic ketoacidosis patients, we would start with the airway, breathing, and circulation as any other patient, of course. So DKA is a multi-system approach. So the main things that we are going to treat is one, we're trying to close the anion gap and treat the acidosis itself, which is the most important part of the management phase. If the patient needs hydration because of the severe dehydration the patient is in, and electrolyte the replacement should be done as well to avoid patients entering into different hyper or hypokalemic manifestations, hypokalemic natremic manifestations as well, and insulin administration. So the goal is to correct these deficits over the 24 hours of treatment to avoid cerebral edema in these patients. And cerebral edema is not seen mainly in adult patients, but in pediatric patients. So step one, rehydration. First step of managing a DKA patient is in trying to give initial 2-liter isotonic normal saline for adult patients. The dose is different, of course, in pediatrics. It would be 10 to 20 ml per kg. You should continue isotonic saline until the hyponatremia is corrected. If you feel the patient has a good hydration status, if they were hypotensive before and became normotensive, that's a good indication as well. As soon as the patient is reaches normal levels of sodium, then you should consider switching to half normal saline. The third goal is once the glucose level goes down to around 250, make sure to, if you're still on insulin therapy, then the patient is on insulin therapy and the anion gap is still ongoing. You don't want to go into hypoglycemia and make the patient worse. So you would switch to glucose containing fluids such as D5 normal saline or D5 half normal saline. In the pediatric patients, it's common to see hypoglycemia, and one of the worst outcomes of managing DKA is cerebral edema in the pediatric population. So do not exceed 40 ml per kg in the first 4 hours for pediatric patients, as they have the high risk of cerebral edema. If you do that, then that's one of the steps of trying to avoid cerebral edema in pediatric patients, and you will be on the safe side. So number two, after fluid replacement, you should measure the serum level of potassium before administering an insulin, because the insulin has one of the properties of insulin, it will push the potassium from the intravascular area into the cellular area. So if a patient's potassium is around 4 and you give insulin, this patient's potassium could go down to 3 or 2.5. Without correction, patients who are hypokalemic could go into arrhythmias and become worse. So any patient who has a potassium level initially below 3.5 should receive IV correction of potassium prior to administration of insulin. In patients who have a normal level of 3.5 to 5, remember, these patients do not reflect the true number of the level of potassium in their body. So if you see a normal level of potassium, then you should also start potassium, but you should also start insulin therapy as well. once the level is normal. If the patient has elevated potassium, which could be seen in DKA levels of 6 or 7, before even continuing the management with fluids and thinking about replacing the potassium. Once you start the insulin, you should obtain an ECG immediately, because if the patient has hyperkalemia and has ECG changes, then the management here would be managing both scenarios, which is diabetic ketoacidosis and hyperkalemia. Hyperkalemia and ECG changes seen, whether it's wide QRS or VTAC or VFib. Patients need to receive IV calcium in the form of calcium gluconate or calcium chloride to stabilize the cardiac membrane. Insulin would push the potassium cells intercellularly, so you have a mechanism that is lowering your potassium level. If you want to give nebulizers such as albuterol, it will do the same effect as an insulin. And you can repeat that a couple of times if the patient has persistent elevated potassium level. And if the potassium level is still refractory while you're treating the diabetic patient and he's still in acidosis, then that's basically the worst case scenario in DKA. These patients definitely need dialysis. So insulin, as we said, after we measure the serum potassium level, and if it's a normal potassium level, then you should start insulin drip. Old textbook used to say, and it's still common practice in some hospitals, unfortunately, doctors give insulin boluses and then follow that with insulin drip. This practice has been abandoned for some time because, especially in pediatric patients, giving boluses of insulin somehow leads to patients developing cerebral edema. So, in multiple worldwide researches, they've compared boluses to insulin drips, and they found insulin drips at 0.1 units per kg, which is the normal dose of insulin, and even half the dose of insulin is sufficient to decrease blood glucose levels in patients with DKA. So don't give insulin as a bolus. Always go with insulin drip. If a patient is like average of 80 kilograms, then you want to give between 4 and 8 units maximum. And titrate as needed. So you need to be repeating the blood glucose frequently, every 30 minutes or 1 hour, and see until the patient is coming close to normal glycemia. Then that's when you want to switch from IV to subcutaneous insulin, or switch the fluids to dextrose containing fluids if the patient is still acidotic. Do not initiate insulin therapy. Yeah, okay, we've mentioned this part about the potassium. So what is the role of sodium bicarb? A lot of people would see patients being treated, DKA patients treated in the emergency department, and you would hear someone say, give the patient sodium bicarb, his bicarb is low, we should give sodium bicarb. Sodium bicarb is actually not going to be beneficial for patients in DKA. It's actually going to be harmful because it's going to cause a paradoxical cerebral spinal fluid acidosis. So now this patient has metabolic acidosis going on in his body, and then he develops acidosis in the CSF, which is not going to be corrected easily. And if you correct the acidosis in the patient's body, you will not be treating the CSF acidosis. And also, most textbooks mention that patients will not need bicarb even if the bicarb is low. This is it will be compensated eventually by the body once the patient is out of acidosis. But most textbooks would recommend giving bicarb as a final medication if the pH is severely acidotic or acidemic below 6.9. and evidence of shock is present. So what are the complications of diabetic ketoacidosis? So we're treating patients with acidemia, with ketosis and dehydration. So one of the electrolytes that the patient is losing is potassium, so hypokalemia, hypophosphatemia, and hypoglycemia. Other complications, whether it's related to the acute disease itself, loss of airway. So patients who have decreased level of consciousness are disturbed, GCS is 8 or below. These patients, you do not want to wait until they become better. I've seen some people do that kind of practice. This is wrong. If you have a patient with a low GCS, you should intubate immediately. Patients who are septic, you should start managing the sepsis with broad spectrum antibiotics. You're already giving IV fluids. If the patient is still hypotensive, start them on norepinephrine and find the source of the infection. Patients who enter in myocardial infarction, you need an ECG and troponin level, and you start managing those patients as well. Hypovolemic shock should be corrected by fluids and vasopressors. Later complications is recurrent anion gap metabolic acidosis. So patients go out of the anion gap acidosis and they relapse again. Or they enter in a non-anion gap metabolic acidosis. This is seen in patients who have received large amounts of normal saline over a long time, and they could develop a non-anion gap metabolic acidosis from the normal saline. So these patients should be evaluated once you interpret the VBG and you think there's another hidden non-anion gap metabolic acidosis, consider switching to Ringer's lactate. Vascular thrombosis is one of the complications of DKA, and mucormycosis, which is a fungal and deadly infection that you do not want to see in a patient ever. Okay, so we were talking earlier about cerebral edema and how it happens in pediatric patients in DKA. The best practice to prevent these is one, slow reduction of osmolarity during treatment. Avoid large volumes of hypotonic fluids. So we said we would not give pediatric patients more than 40 ml per kg. Then you would be on the safe side while treating pediatric patients with DKA. Your goal is to decrease the glucose slowly as possible. If you decrease the glucose fast, or a patient develops hyponatremia fast enough, then this would lead to cerebral edema, and you do not want that. Avoid unnecessary bicarb during treatment, as we mentioned. Avoid hypoxia by either giving patients supplemental oxygen, or if they are altered, you should intubate them. Avoid hypokalemia, hypophosphatemia, and hypomagnesemia. So you need to be repeating the urine and electrolytes at least every 2 hours maximum. Disposition. Patients who are have severe DKA and are still kind of unstable while treating and trying to get them out of the acidosis, but they're still sick, should be definitely admitted into ICU. Many hospitals here would admit patients with DKA, whether it's simple or profound DKA, into ICU settings immediately. However, if a patient has DKA and it was initially caught and treated within the first few hours and the patients become stable, I would recommend medical team admission. Some books say you can discharge a patient with DKA, but honestly, I don't think that's safe. Patients should be admitted. We should find the source or cause of why this patient entered into DKA. Even if it's about patients who are not compliant about insulin, these patients really do need proper education about insulin, how to use it. Maybe they're misusing it. Maybe they're using different types of insulin that are not compatible to them or their disease. they're using it in a wrong route, it may be expired. So please do not discharge any patients who develop DKA at any point. Okay, we have the final part of today's lecture, which is hyperosmolar hyperglycemic state. A hyperglycemic state is similar to the diabetic ketoacidosis, except that we don't have any acidosis going on, and the blood glucose levels are shooting way up, higher than 700 milligrams per deciliter, which is not normally seen in DKA. These patients, because of their severe hyperglycemia, would have severe, profound dehydration. We're talking about 8 to 12 liters of fluid deficits, which is concerning. Patients, this disease used to be have the word coma in it because of the altered mental status that patients present in, but it's not a true coma. So they changed the name of the disease recently to HHS, which is a description of the state that they're in, and it's more appropriate naming for the disease. So the symptoms and signs of patients of HHS would be the same as patients with diabetes symptoms, which are the same as polyphagia, polyuria, polydipsia, but they could present in weakness, fatigue, altered mental status. Patients could have focal neurological deficits. You would see signs of dehydration, whether it's decreased skin turgor, dry mucous membranes, prolonged capillary refill during examination. Diagnosis of HHS. The blood glucose is usually over 700, but anything above above 700 would be immediately diagnosed as HHS. But always order a VBG and make sure if the patient is acidotic or not. These patients could have another cause of acidosis. They could have another cause of metabolic acidosis, which makes it difficult to differentiate. But the clue in these patients is the elevated blood glucose. If you do serum ketones, you would see that the patient does not have any ketone body circulating in the body. So that also would help in diagnosing HHS. Management, we would have to identify and treat the precipitating event eventually. The treatment is very similar to the diabetic ketoacidosis patients. We're giving fluids, and making sure the patient is rehydrated as soon as possible. So we're gonna give 1 to 2 liters of normal saline as boluses within the first 2 hours, and then we would have to continuously assess the patient and see if they're still dehydrated. Then you give another bolus and another bolus, and follow up with the blood gases and electrolytes and blood sugar levels every hour. After the first 12 hours of management, you want to switch to half normal saline instead of the normal saline that was given in the beginning of the management. Potassium replacement, the same management protocol as DKA. Insulin, also as DKA, would start with 0.1 unit per kg per hour if the potassium level is normal. Until the patient reaches almost normal levels. Up to 300 is acceptable, 300 milligrams per deciliter of blood sugar. Make sure you just order magnesium and phosphate levels as well with the other electrolytes, and correct any hypomagnesemia and hypophosphatemia. Thiamine administration, I've never seen that in our ER department. But if you have a patient who has malnutrition, then you should give thiamine replacement. All patients with HHS should be admitted in an inpatient setting. So let's just review the diabetic emergencies that we've spoken about. How can we diagnose a diabetic patient in the ER? There are a lot of different ways to diagnose diabetes in the emergency room. We're usually using the random blood glucose. Any level above 200 is definitely a diabetic. And inpatient settings, they can use fasting plasma glucose concentrations or the post-load OGTT level and compare both between 2 hours and see if there's any elevation. HbA1c is an accurate reading of blood glucose level over the past 3 months of the patient's eating habits, and it would show how well they are maintained on their diabetic medications. So anything above 6.5 means that they're diabetic if they've never been diagnosed before. The goal is around 6.5 to 7 for patients who are taking their medications. And unfortunately, any level above 11, that means the patient should be switched from oral hypoglycemic medications to insulin therapy. DKA is diagnosed by presence of hyperglycemia, high anion gap metabolic acidosis, and elevated ketoacid levels. Management is fluids, rehydration, make sure the potassium and other electrolyte levels are normal, and start insulin therapy after making sure the potassium level is okay. And the main goal of managing DKA is closing the anion gap. Use of sodium bicarb has not shown any benefit. It actually can have worse outcomes for patients with DKA. In HHS, they usually present in older comorbid patients. Diabetic peripheral neuropathy is something we did not talk about in this lecture, neither it or diabetic foot ulcers. I know it's a part of the emergency topic, but I just really did not want to give you so much information to obtain in one day. I'm sure it's a very important topic to be mentioned in some other conference, inshallah, someday. Hypoglycemia. Hypoglycemia is easily missed. It's one of the vital signs. Keep that in mind. If you catch it early, then it's an easy management that a patient would improve immediately within 5 minutes in front of your eyes. If you miss a patient with hypoglycemia and they develop these complications and become having acute brain insult and permanent damage to their brain, it's really something that you don't want to see ever during your medical profession. Keep in mind that sulfonylurea medications are hypoglycemic agents that could cause hypoglycemia. So you have to keep that in mind in patients. Always go through the patient's medication, ask them if they're taking the medication from the same hospital, look it up. If not, a lot of people bring their medications with them in bags and just check the name, make sure it's whether it's a sulfonylurea or other agent. If it is, then you should consider the other managements besides insulin, whether it's octreotide for the hypoglycemia patients who are on sulfonylurea for prolonged periods of time. If you have any question regarding the references, I've brought all these. The slides were from Rosen's emergency medicine textbook, Tintinani emergency medicine textbook. I like this website. I recommend people who are junior residents or people who are interns or students that are interested in ER and want to review quickly some of the major topics. Crackcast is basically Rosen's emergency medicine condensed into notes. You have them talking in audio lectures and also PDF notes that you can print and keep with you. First aid is nice for people who are just getting into emergency medicine. It's simple, it's easy to read. I think both those sources would benefit you guys. So if you guys have any question regarding the lecture, please let me know. It was really a pleasure to present to, mashallah, the audience is at least 50 people. I'm really honored to be here with you guys. Thank you to all the organizers and the audience for attending. Thank you to all SASIM members for giving me the opportunity to present this lecture. And let me know if you have any questions. Feel free to ask.
شكرا دكتور احمد. اعتقد دكتور عبد الله العامري عنده شيء يقوله. تفضل دكتور عبد الله.
السلام عليكم ورحمه الله وبركاته. اولا بس اعرف انا نفسي، انا الدكتور عبد الله العامري، انا مبتعث سينيور امرجنسي ريزيدنت. الله يسلمكم. اولا احب اشكركم على هذا الكورس، بصراحه كان مفيد جدا، حتى لنا بالنسبه لنا كامرجنسي فيزيشن او ريزيدنت كان ريفرشمنت، وخاصه انكم جالسين تأدونه فولنتري، يعني ما في بيمنت، فاشكركم جدا جدا عليه، والقائمين عليه ايضا المعدين له. صراحه شيء انا حريص عليه بصراحه، مع اني مبتعث وفارق التوقيت وهذا كله، لكن من جوده الكورس انا كنت حريص جدا عليه. ثاني شيء بس احب بالنسبه للي يبغون ينضمون للامرجنسي، اول شيء الامرجنسي is a passionate subspecialty. If you like it you will enjoy it. وبعدين ما يعرف الامرجنسي الا الواحد لما يشتغل بالامرجنسي. and it's really enjoyable subspecialty. الشيء الثاني بالنسبه للمحاضر اليوم، دكتور احمد غطى تقريبا كل شيء وكفى ووفى، لكن بالنسبه لكم كستودنت او even practitioner، الباثوفيسيولوجي اوف pathogenesis, pathophysiology, mechanism of action, it's important. It's really very important. لأنه لما تعرف الشيء كيف جاء، تعرف الميديكيشن لما تعطيها إيش حتسوي بالضبط، حتعرف تعالج مريضك. يعني أضرب لك مثال، ستيرويد، الهايبرثيروديزم، في الادرينال insufficiency. ليش يكون عندك إديمة في الاثنين هذولا؟ أول شيء أنت تعطي ستيرويد في الهايبرثيروديزم ستورم علشان الأوفر ويلمد أوف كورتيزول برودكشن يسبب لك بارشال أدرينال insufficiency. طب إيش فائدة الكورتيزول والستيرويد في الموضوع؟ لأنه يسوي لك inhibition to convert non active thyroid hormone, circulating non active thyroid hormone to active form. هذا من جهة. طيب كيف يصير عندي إديمة؟ الكورتيزول أصلاً جالس يسوي لك inhibition لل ADH production. إذا ما عندي ستيرويد يصير production high، ويصير عندك retention، فلذا البوينت انه الميكانيزم باثوفيسيولوجي and pathogenesis is very important. شكرا لكم على اتاحه الفرصه لي، وبالتوفيق جميعا.
الله يعطيك العافيه دكتور.
الله يعطيك العافيه دكتور عبد الله.
بس انا واحده انا
تفضل دكتور.
مو ماسك اني اورجنايزر بدايه الكورس كل محاضره احضرها وما فوتت ولا دقيقه عشان استفيد. انا نفس الكلام يعني، ممكن انه اللي بيقدموا زملائي في نفس الليفل اللي احنا كلنا، لكن انا استفدت منهم مره كثير. يعني كل محاضره بحس لا والله في حاجه في البيزك نولج بستفيد منها. بس شهادتي هذه مجروحه تماما. بس انه انا مداخلتي عشان دكتور عبد الله. دكتور عبد الله انا ملاحظ يعني في كم اسم throughout the last lectures الفور ولا 5 lectures، ملاحظ تماما انه دكتور عبد الله اسئلته كذا غريبه. يعني you are beyond الليفل حق الميديكال ستودنت. ما كنت اعرفك والله، بس كل الكويشن حقتك ما شاء الله تبارك الله للمحاضرات، سواء محاضره الدكتور مقادمي، سواء محاضره دكتور عمار، كم في كذا كويشنز. فانا مره شاكر لملاحظاتك، شاكر لاقتراحاتك، شاكر لكل البقيه اللي حضورهم اعطاهم وقتنا، والله يكتب ذلك ان شاء الله في ميزان حسنات الاورجنايزرز والسبيكرز والاتند كله.
اشكرك دكتور احمد، وهذه شرف لي اني احضر معاكم، والحمد لله كنتم موفقين جدا والله يعطيكم العافيه. بس في نقطه اذا ممكن تخليني اقولها، في احد سال عن كيف اشخص الثيرويد ستورم في الامرجنسي. طبعا زي ما تفضلت انت انه غالبا يكون عندك باك جراوند هايبرثيروديزم، لكن في حالات انت في الامرجنسي انت ما تعرف احيانا الباك جراوند حق البيشنت، بس الهيستوري از امبورتنت لانه غالبا تكون عندك sudden severe and extreme symptoms of hyperthyroidism. فمن هنا تقدر تسسبكت الستورم وتبدا في الانفستيجيشن او الانيشيت المانجمنت. ومره ثانيه اشكركم وبالتوفيق ان شاء الله، وان شاء الله القادم نكون مشاركين معاكم. هذا اللي كان ان الفائده تعم. والاسئله حقتي كانت بحكم اني مريت في الموضوع وفي اشياء ممكن تغبى عني او في اشياء مهمه انه الناس لازم تعرفها، الطلاب او البراكتيشنرز. فهذه كانت اسئلتي، واتمنى اني ما كنت ثقيل عليكم. السلام عليكم.
الله يعطيك العافية دكتور عبد الله، ودكتور عبدو كمان الله يعطيك العافية. وشكرا دكتور أحمد، كانت محاضرة رائعة وفيها معلومات قيمة ومهمة جدا، وشكرا لتواجدك معنا. وقبل ما نختم بآخر فقرة اليومنا الأخير، حابة أقول كلمة كذا بسيطة لكل فيزيشن، لكل نيرس، لكل باراميديك في الإمرجنسي ديبارتمنت. أنتم أبطال، وأثناء هذه الجائحة أثبتتم أنكم أبطال. أنتم وجه المدفع في محاربة جميع الأمراض وليس هذا المرض فقط. أنتم الأساس في أي مشفى. أنتم الذين تطمئنوا أي مريض أتى لقسم الطوارئ يتألم. أنتم الذين تخففوا الألم عنه لأول مرة. أنتم الذين تواجهوا عصبية أي مريض أو أي مرافق وتمتصوها، وفي المقابل تمروا بمواقف صعبة جدا يوميا، من موت أو من أخبار سيئة توصلوها للمريض أو لأهله. وفي هذه الجائحة، وبالرغم من الصعوبات اللي واجهتوها، وبالرغم من التعب الجسدي والنفسي وبعدكم عن أهاليكم، كنتم جيش الدفاع، تمسكتم بروح التواجد في الخطوط الأمامية، وأصريتم على التمسك بعقلية لن نركع أمام العقبات ولن نهزم في هذه المعركة. Be proud to be emergency physician. Be proud to be a paramedic. Be proud to be emergency nurse. في هذه الأيام الفضيلة اللهم ارفع عنا هذا البلاء والوباء، وارفع الغمة عن هذه الأمة يا رب. ولأن من لا يشكر الناس لا يشكر الله. نختم الكورس معك يا صدقة، تفضل.
أنا عاجز عن الشكر والله، يعني حشكر مين ولا أشكر مين؟ فأول حاجة خلينا نبدأ بالمستجدات الأخيرة. أول شيء شكرا لكل الحضور اللي وثقوا فينا واللي قاعدوا معنا إلى دحين واللي استمروا معنا خلال فترة الكورس بالكامل. شكرا لكل الدكاترة اللي شاركوا معنا كحضور وأثرونا، زي دكتور عبد الله العامري. دكتور عبد الله ترى يعني ما حتهرب بهذه السهولة، بما أنك أنت جيتنا بنفسك، فإحنا حنتمسك فيك، حنستفيد منك كثير إن شاء الله في المستقبل. في كمان شكر يعني بسيط جدا. أول حاجة شكرا لكل السبيكرز الرهيبين اللي شاركوا معنا، شكرا لكل الباراميدكس، شكرا لكل الدكاتره الكونسلتنتس الريزيدنتس اللي اعطونا من وقتهم، اللي اعطونا من علمهم، اللي اعطونا من بركه علمهم ومن خبراتهم. الشكر واصل لهم من اول، ونشكرهم الان في غيابهم وفي حضورهم، ونشكرهم ان شاء الله بالدعاء لهم وباستثمار العلم اللي اخذناه منهم، وندعو لهم انه الاجر ان شاء الله يعود اليهم باذن الله. شكر خاص لفريق العمل الرائع. يعني انتم يمكن ما تعرفوا قد ايش الفريق هذا قاعد يشتغل وقاعد يكرف. صح انه الميتينجز هذه قاعدين نعملها اونلاين، ما فيها الفيزيكال، يعني ما فيها التعب الفيزيكال اللي بيكون موجود في المحاضرات اللي بتكون يعني حضوريه واللي يكون فيها ورش عمل، لكن كل هذه كانت تجربه جديده علينا، كلنا تعلمنا اشياء مره كثير، فكانت تجربه رهيبه. فشكر اول حاجه لمودة فلاتة، شكرا مودة على جهودك العظيمه كرئيسه للجنه العلميه في نادي ساسم، ورئيسه للمشروع بشكل كامل، يعطيك الف عافيه. شكرا خديجه الشاكري كونك كنت نائبه الرئيسه في اللجنه العلميه ونائبه الرئيسه في المشروع. شكرا اراده الغامدي، اعتقد انها ما هي موجوده، مشغوله باختبارها اعتقد. اراده كانت من الناس اللي تعبوا كثير معانا في المشروع. شكرا محمد جمال باراميديك معانا من مدينه الملك عبد الله الطبيه، اكثر الشباب اللي اشتغلوا وكرفوا كمان في المشروع، وكان له بصمه واضحه جدا في اكثر من مره. شكرا غيداء في الانبان مستضيفتنا في اكثر من لقاء، وشكرا على كلماتك الطيبه ودعواتك اللطيفه في الاخير. شكرا حميده، شكرا اسراء شريف، شكرا تركي الحساني، شكرا غاليه فتيه، شكرا رؤى نجار، شكرا غدير منشي العامله من خلف الستار الاعلاميه الرهيبه، شكرا تاله في الانبان، وشكرا لحبيبنا عبد السيد اللي ما شاء الله تبارك الله في كل مكان معانا، في الميتينجز حقت النادي معانا، وكمان في الاورجنايزنج حق السمر كورس معانا، وكمان في البرزنتيشن حق السمر كورس معانا. شكرا لكم جميعا. نتمنى انه احنا ما كنا ضيوف تقال عليكم، نتمنى انه احنا فعلا ادينا اللي علينا وكنا فعلا على قدر الثقه، ونتمنى انه نشوفكم ان شاء الله في لقاءات اخرى وفي مشاريع ثانيه. حنرسل لكم رابط للفيدباك، اتمنى من الجميع سواء سبيكرز اورجنايزرز حضور، اتمنى انكم تشاركونا بالفيدباك حقكم. ممكن تتواصلوا معنا على حساباتنا الشخصيه او على حساب جمعيه ساسم في تويتر، ونراكم على خير، وكل عام وانتم بالف خير. سبحانك اللهم وبحمدك، اشهد ان لا اله الا انت، استغفرك ربي واتوب اليك.